Welcome to the webinar entitled Changes in the Assessment of Medicines at the National Institute for Health and Care Excellence, NICE, in England and relevance to Australia. To formally start the proceedings, I would like to acknowledge the traditional custodians of the land throughout Australia. We recognise their continuing connection to the land, waters and sky, and thank them for protecting them in the past and fighting for them now for the benefit of future generations. I would also like to pay my respects to their elders past, present and emerging, and extend that respect to all First Nations people present today. I would also like to acknowledge the many lands that we are on today, with many people joining us from all around Australia. I'm on Wangal land in the inner west of Sydney, part of the Eora Nation. So my name is Bonnie Parkinson, and I'm an Associate Professor of the Macquarie University Centre for the Health Economy and also the Australian Institute of Health Innovation. I co-lead a team of researchers conducting evaluations with Professor Martin Hoyle for the Pharmaceutical Benefits Advisory Committee and the Medical Services Advisory Committee. Unfortunately, Martin Hoyle's sick at the moment and will not be able to join us, so I'm going to be taking his place as chair today. MUCHE also conducts research into health policy, healthcare funding, aged care, mental health, disability and aged care. With me today, I have several amazing presenters and I'm really looking forward to listening to them today. The first one is Ian Watson. He's Senior Technical Advisor in the Health Technology Assessment Methods team at the National Institute for Health and Care Excellence, NICE, in the UK. Ian oversaw the design and delivery of NICE's recent review of its processes and methods of health technology evaluation and led the updated methods. He's joined today with Lorna Dunning, who's HTA advisor regarding technical appraisals at NICE. And with Ian, Lorna was responsible for delivering updated methods. We also have Zoe Garrett that's joining us today. She's a Senior Technical Advisor regarding science policy in the Science Policy and Research team at NICE, and she supports NICE's international strategic partnerships. So the first half of today, or the first part of today's session, I will provide some context with regards to the presentations today with regards to NICE, the NICE HTA review and how that relates to the upcoming PBAC HTA review. And then Ian, Lorna and Zoe will talk to us both about the HTA review and also international collaboration with HTA agencies. After we see their presentations, we'll follow this with some brief thoughts by myself regarding the relevance of the NICE HTA review to Australia. And finally, Professor Kirsten Howard will present also with regards to the relevance of the NICE review to Australia. Professor Kirsten Howard is co-director of the Menzies Centre for Health Policy Economics and Professor of Health Economics at the School of Public Health, University of Sydney. She's chair of the Economic Subcommittee of Pharmaceutical Methods Advisory Committee, or PBAC, and is a member of PBAC. And I've known Kirsten for well over a decade now. And I'm very excited to for this presentation tonight and to kind of bring together people from both the UK and Australia and learn from both organisations. There will be an opportunity for attendees to answer questions to any of the speakers at the end. Please post questions anytime during the presentations using the Q&A button. However, we will address them at the end and I'll direct those questions to whoever is probably most appropriate to answer the question. But obviously, if it's a question for all presenters, everyone will get an opportunity to ask questions. So firstly, just a little bit of context. There have been several reviews just recently with regards to Health Technology Australia, and there are a couple key ones that are coming up. So recently, there was a Senate inquiry into approval processes for new drugs and novel medical technologies in Australia, which was run over 2020-2021, which culminated in what's colloquially known as the Zimmerman Report. This involved a large number of submissions from all different parts of society, as well as public hearings as well. The report has 31 recommendations, and the key one that I wanted to point out was recommendation 3, which suggests that the office should consider collaboration with the National Institute for Health and Care Excellence in the United Kingdom to establish similar clinical evaluation processes in Australia that links in with Australian health technology assessment processes, which I think is the catalyst for today's seminar or webinar. There was also a very recently announced, actually, an international collaboration agreement between the Australian government and a range of health technology assessment agencies, including NICE, but also including CADITH in the UK and Scotland, Wales. And this, there's also a framework, or the aim is to provide a framework to support shared strategic objectives in a couple of priority areas. COVID-19, future-proofing HTA systems, particularly with regards to sharing methods, collaborating with regulators, work sharing and efficiency gains with regards to considering dossiers of evidence and digital and artificial intelligence. Currently, which is underway, is the National Medicines Policy Review. The National Medicines Policy was first published in 2000, and a large amount of things has happened since then, and really ultimately needs updating. It's a high-level policy framework focusing on access and safe use of medicines, and kind of underpins a lot of the HTA work from that. Consultations on the draft policy were recently closed, and the policy is due to be finalised at the end of this year. And finally, in Australia, there's the Health Technology Assessment Review. So the current Pharmaceutical Benefits Advisory Committee guidelines was last updated in 2016. They were first published in 1991, 1992, and each, every couple of years they are updated. But this is, the aim is to do quite a wide-ranging review of them. It leads from a strategic agreement between the Australian Government and Medicines Australia and the Generic and Biosimilar Medicines Association. In addition to a bunch of other agreements with regards to pricing and a variety of other issues, there's 2 things that I want to point out, 2 agreements. The first one is to provide for there to be early advice from the PBAC regarding whether the base case discount rate, which is currently 5%, aligns with international best practice. The review and submissions were conducted in 2021, earlier in 2022 this year, but the final position is to be announced. And then secondly, there's also meant to be an independent detailed review of HTA policy and methods. The committee was announced in April 2022. However, since then, the terms of reference have yet to be announced, and obviously the review is yet to be conducted. In the UK, the NICE has a methods guide or manual, which was last updated in 2013. And there was a commitment under the 2019 voluntary scheme for branded medicines pricing and access to review the methods guide and manual. The review was initiated in July 2019, and it was quite wide-ranging. It covered 4 of NICE's programs regarding technology appraisal, highly specialised technologies, medical technologies, and diagnostics. And it covered both topic selection, processes in general, and methods. And the final updated consolidated methods and processes manual and topic selection manuals were published in January 2022, so fairly recently. So the question for today is, what can Australia learn from NICE's recent HTA review? I would like now to introduce the first two speakers from NICE, Ian Watson and Lorna Dunning, and they will talk about the recent NICE HTA review.
Thank you, Bonnie, and hi, everyone. It's really great to be here and talking to you today. And it's a nice coincidence, maybe rather fitting, that this webinar falls on this year's World Evidence-Based Healthcare Day, which emphasises the value of better evidence to inform healthcare. So it's a great opportunity for us to be talking about how we can use our HTA methods to make the best use of evidence in our decisions. And as it happens, this year's theme for World Evidence-Based Healthcare Day is about partnerships. So it's also great that we can speak a little bit more about how we can collaborate across the HTA community around the world. And with that, I shall share my slides, so hopefully you can see that. And I'll talk a little bit about the NICE methods review. I'll start off by just giving an overview of the review, how it was conducted, what it was aiming to do. And then with Lorna, we'll spotlight some of the key updates, particularly around modifiers, uncertainty, and a comprehensive evidence base. We'll talk about some of the challenging technologies, conditions, and evaluations, things like cell and gene therapies and rare diseases and innovative medicines, and also touch on some of the process updates and the alignments that we've made. Before finally, I'll talk about where we go next, because the journey with methods is never over. So onto the methods review. What were we trying to do? As Bonnie mentioned, it was some time since our previous update to our methods. So an update to our methods was due, with the specific trigger of the agreement in the voluntary scheme initiating that process in 2019. And we're really seeking to update our evaluations to make sure that they've been reviewed and aligned and updated, and to make sure that they are flexible and adaptable and robust, to make sure that our evaluations are evidence-based and they're future-proof and they're predictable, with benefits for patients, for the life sciences industry, and for the NHS. As Bonnie also mentioned, this covered medicines, devices, and diagnostics, and highly specialized technologies altogether. And we looked at methods and processes and topic selection. And we did all that in the context of the health and care system. I think it's worth emphasizing that NICE doesn't operate in a vacuum, and we need to think about how our methods and processes interact with that health and care system. And for most of this talk, I'll emphasize, focus on the methods, but I'll also come back to process briefly at the end. So how did we go about the review? Well, it really fell into two sort of core stages, I guess, which we sort of loosely termed the what and the how. So firstly, we looked at what changes are needed to be made, what changes are needed, and looking at the evidence and the case for making changes to our methods. We specified the questions, we reviewed the evidence to build up towards, should there be a change in our methods? And from that, we took that for a public consultation. And then from that, we built into the second phase, which is how to go about introducing changes to the methods through the decision-making framework and a methods manual. So we designed those methods and we drafted that into what then became the final manual, and we're now in that final phase in the bottom right of implementing the methods into practice. The scope of the review was broad, but it didn't start from an empty sheet of paper. As we know, NICE has had methods guidance for years, and we really emphasised that this was always setting out to be an incremental development of our existing approach. It wasn't ripping it all up and starting again from a blank page. It was building on what we already had. But emphasizing that we needed to review and amend the methods if changes are clearly needed and well justified. So it was about an evidence-driven, evidence-based change to our methods. That then led to a detailed review in the first phase of 10 topics, which are shown on the left-hand side of this slide. So costs, cost minimization approaches, decision-making, discounting, of course, was an important topic. Equality, health-related quality of life, modifiers, which we'll come back to in some detail. The evidence base, technology-specific issues, and uncertainty. And from those 10 topic areas we built into updates that span the 5 key sort of headings or areas. I guess I call these headings on the right-hand side. And what do those changes look like? So in terms of the breadth of the updates, we made a very wide range of updates across those 5 headings, which are kind of summarized on this slide here. The first heading, the valuing the benefits of health technologies, is where we see updates around our modifiers and discounting, and this is what we'll come back to in the next section. The improving the evidence base was really about making sure we are getting the best out of the evidence that we have available, making sure that it's sourced and synthesized and presented correctly and appropriately and robustly, and valuing a broad evidence base, including things like real-world evidence, surrogate outcomes, qualitative evidence, different sources of costs, and updates to health-related quality of life. So, for example, our approaches to EQ5D, the 3-level and the 5-level versions, how we deal with age and carers and family members. Under the third heading of structured decision making, we made updates around how we present analyses, how we make decisions for lower cost, lower benefit, Southwest Quadrant technologies. We thought about and introduced some new non-reference case exceptions, so some options for particular circumstances, how we present our guidance, and how that all comes together into a single decision-making framework. Thinking then about challenging circumstances, we thought about the conditions, the technologies, and the evaluations that challenge the methods of health technology evaluation at NICE. And we considered whether there was a need for specific methods and considerations for particular technologies, technology types, advanced medicines, for example, or conditions or evaluations. And within that, we also looked at the need to introduce more advanced methods that are particularly relevant to innovative medicine. So, for example, cure and cure proportion modeling, which might be particularly relevant in, say, cell and gene therapies, basket trials, which are becoming more interesting in a number of disease areas, including histology-independent cancer medicines. And then finally, the final heading is around alignment of our methods. And we mentioned that the methods update covered medicines, devices, and diagnostics. And we wanted to bring all of that together into an aligned, single consolidated methods manual. We aligned our approaches to cost comparisons, which in the past differed between medicines and devices. And we also aligned the programs that we operate to simplify things for everybody, make things more straightforward and more consistent, but allowing for differences where differences are needed, where there are relevant differences between medicines and medical devices, for example, or between devices and diagnostics or medicines and diagnostics, to allow for relevant differences where they're appropriate. So that gives a flavor of the breadth of the updates without wanting to go into every single one of them. But I thought it would now be a good opportunity to spotlight some of those key updates, which I think are particularly important. So I'll start off by talking about modifiers, and then I'll hand over to Lorna, who will talk you through our updates around uncertainty and the comprehensive evidence base. So I've used the word modifiers a few times now, but what are they? What do we mean by modifiers? And very simply, it's anything that can modify a decision or modify our view of the clinical benefit and the value for money of a health technology. So it might be characteristics of the patients or the disease of the technology that impact or influence or modify our interpretation of clinical benefit, value for money, and our decision. Modifiers, it's important to emphasize that we need to be cautious in applying modifiers. So NICE's principles have always been that a quality is a quality is a quality. A health benefit is of equal value regardless of where and how it arises, except in specific exceptional circumstances. And that carries through when we're thinking about modifiers, that we shouldn't be using them everywhere. They should be used in appropriate exceptional circumstances. And by appropriate, I mean supported by evidence of societal value or reason justification. So there needs to be a good reason why we are taking into account a consideration and influencing and modifying our decision. And that can work either qualitatively or quantitatively. So it could be a specific weight, a specified weight that we apply to health benefits, or a QALY weight, or it could be taken into account, say, deliberatively during a decision by a committee. It could be a qualitative factor. As part of the methods review, we looked at a large number of different modifiers. They're summarized on this slide. So there's nine of them that we've put up here. Some of these will already be familiar. Some of them were newer considerations. In particular, we know about end of life. NICE has been using end of life as a modifier for many years now. But you may also have heard about the shift now from end of life towards severity, which I'll talk about a bit more. So the first stage, as I mentioned, was to really think about the evidence and the reason justification for why we would want to consider a modifier. And in the case of end of life, the review found that really was limited evidence that society placed additional value on health benefits, specifically in end of life conditions. And in particular, there wasn't consensus about whether we should give special consideration to technologies that specifically extend life expectancy, or whether we should think about ones that also improve quality of life, or both, or either or. There wasn't consensus there. But what there was evidence was that society does value more highly health benefits for more severe conditions. Of course, this correlates with end of life. A condition that is at end of life, something that shortens your life, is often going to be severe. So there's an overlap there, but it is important. There's an important difference. And we also found then that when we think about severity, we should not only think about shortening life, but we should also think about the loss of quality of life. And as a result, we led to this conclusion that we should remove the end of life as a consideration and replace it or add in a severity or burden of illness consideration. And this I'll come back to in a second to talk about how we actually went about doing that, how we went about delivering that conclusion. Thinking about some of the other modifiers. So firstly, innovation. That's often been, it's always been a consideration for NICE, and it is an important part of our principles that we support innovation and encourage innovation. But there has been some inconsistency in how it's been considered and recorded. And there's no particular evidence that benefits from innovative technologies are valued more highly by the public than from a non-innovative. If you're getting a quality gain, a quality benefit from a medicine, does that depend on, does the value of that depend on how, inverted commas, innovative the medicine that you were given was? And as a result, we propose to remove it as a specific modifier, but make sure that the challenges and benefits of innovative technologies are captured, and therefore clarify how that's captured throughout the evaluation and through the committee deliberations. On to rarity next. So that was another thing that we were tasked with thinking about. Should there be additional consideration for rare diseases? And the evidence was reasonably strong here, actually, that there's not particular value amongst the public that rarity should be an important modifier. So there was no case for adding a specific rarity modifier, but nevertheless, there was a good justification for why we should make sure we think about the challenges and the values attributed to rare diseases, and make sure that's captured within our approach. We also thought about age and uncertainty. Now, uncertainty, Lorna will come back to, and age is perhaps something I could be a little bit more brief on, but broadly the conclusion was there was no specific need for a modifier for age, but again, to make sure that we're not generating problems associated with age, in particular childhood diseases. So what does that look like? So we can see that there was three of the things that we looked at where there was limited or no case for inclusion as a modifier. Then down to the bottom where there was three where there was a clear case for including severity, health inequalities, and uncertainty as a modifier. So what does that look like when we shift from the 2013 to the 2022 methods? It's a slight shift, and importantly, the shift from end of life to severity, and the shift of innovation away from being a specific modifier but incorporating it into uncertainty. So now just to talk a bit more about how we went about introducing a severity modifier in place of end-of-life considerations. So remembering that this is built on the evidence that people value highly the benefits in health in severe diseases, which is not the case for end-of-life. And so we removed the end-of-life consideration and introduced a severity modifier. And we propose to focus on the severity of the condition with the current treatment. So with the treatment that are currently available in the UK Health Service. And we wanted to make sure we're encompassing concepts such as the burden of illness and the degree of unmet need in our modifier. So firstly, we proposed that it be a quantitative consideration in the same way that end of life was. So in the past, end of life was based on effectively a QALY weight delivered through a change to our cost effectiveness levels, but it was quantitative, and we wanted to replicate that. We also proposed that we consider severity based on absolute and proportional QALY shortfall. A QALY shortfall of the loss of health, the amount of health that people miss out on by having a condition, is a concept that's been around for a long time, and it's been considered by NICE in the past, particularly in our previous considerations of value-based assessment. So that was a valuable tool that we were able to immediately use. And the two ways of considering QALY shortfall, absolute and proportional shortfall, we considered that both of those reflect different ways in which a condition can be severe. So something could be severe because you lose a large amount of health, a large overall total quantity of health, or it could be severe because you lose a large fraction of what you would otherwise have experienced. So we propose to use both of those. We also propose to use a two-step approach. So this reflects the idea that severity is a spectrum. There is a continuum of severity. All conditions have some degree of severity because they all have an impact on people's lives to a greater or lesser extent. But nevertheless, it's not really feasible to have a full spectrum of severity in practice. It would make our decisions quite difficult to implement in the real world. They might become quite unpredictable and quite variable. So we used a pragmatic approach, whether it's sort of more stepwise approach, to help make it more feasible to implement this in practice. So then using that two-step approach, we propose higher weights that are applied to the QALYs for more severe conditions. So this is really reflecting that fundamental principle that people are valuing more highly the health benefits that arise in more severe conditions. So we place additional value on the health benefits that arise in those conditions. And the table in the bottom right shows that's lifted straight from our manual. So you can, if you want to read it, you can go and have a look. That illustrates how those QALY weights are applied. So a lower weight of 1 is applied to most technologies. So sorry, to most conditions, because most things are not exceptional. This is returning to that principle of exceptionality. With a weight of 1.2 available to conditions with a proportional or absolute shortfall in that middle range there. And then the highest weight of 1.7, which mirrors what was used in end of life, applied to the most severe conditions. So how did we go about setting those levels and those weights? So on the left-hand side, this is just a reminder of that principle of exceptionality. So a QALY is a QALY is a QALY, except in exceptional circumstances is the principle here. So we were looking to make sure we were applying a QALY weight to exceptionally severe conditions. But the real benefit of the using a severity modifier over end of life, which was traditionally almost exclusively applied to cancer, was that we could capture a wider range of conditions, a number of different types of conditions, a number of different ways in which conditions can be severe. So having said all that, while we have evidence that society values more highly health benefits in severe conditions, we don't necessarily have enough evidence to say exactly how much. So as a result, we needed a pragmatic solution that was reflective of the evidence, but was possible for us to implement in practice. And we did that by looking back at the severity of the conditions that we'd seen in the past. So we looked at decisions between January 2011 and November 2019, because that was how the data came together at the time. There was the data that was available at the time. So we looked at the QALY shortfalls in absolute and proportional terms. We looked at different types of conditions within that. We looked at, say, for example, children or orphan medicines or cell and gene therapies. We looked at how those worked out within that. And we reached a conclusion based on, as I say, a pragmatic view that we should accept the amount of displacement or opportunity costs that we were seeing with end of life and use that for severity. In the absence of sort of formal evidence of exactly how much we should value severe conditions, we matched it then to the amount of displacement and opportunity costs that will have been accepted and tolerated and achievable in the health service using the end of life. So we built the modifier based on these all of these considerations together, and set those levels, cutoffs, I guess, for proportional and absolute shortfall at the levels that are shown there. As I say, in a way that matched the overall opportunity cost. So we termed this opportunity cost neutral. So it's a similar overall level of opportunity cost to what was used in end of life. I mentioned that we use the QALY shortfall, just as a recap for people who've come across this before. We use both the absolute and proportional shortfall to assess severity. And so QALY shortfall is the amount of health that people lose or miss out on as a result of having the condition. So it's the difference between the health or healthy life expectancy, the total QALYs accrued by people who have the condition when they're having standard treatments or standard care, compared to the total health that people of the same age and sex distribution would have in the general population. So the total difference between that, the absolute amount of difference between that, the difference between area A and area B is the absolute shortfall. And the proportional shortfall then is the fraction of the health loss. So that's the ratio of the absolute shortfall compared to the total health for the general population, the healthy life expectancy for the general population. Just as an illustration of absolute shortfall, so how do you go about calculating that? Bear in mind that the figures on this slide are simplified. They're shown in absolute terms. They're not discounted. The NICE methods use discounted QALYs, but just for simplicity, this is an illustration using undiscounted values. So if people in the general population would live for 60 years at full health, they would accrue 60 QALYs. If people with a condition live for, say, 50 years at 50% quality of life, they accrue 25 QALYs. The difference then is 35 QALYs, and that's your absolute shortfall. As I say, those numbers are purely illustrative. The actual numbers we use are based on discounting, so are much smaller. So absolute shortfall lies between 0, which means the condition has no impact, and the highest number of QALYs for the general population. Based on discounted QALYs, that's around 24, 25. Proportional shortfall then is the fraction. Again, the simplified example using undiscounted QALYs, the same numbers here, but then dividing the 35 absolute shortfall divided by the 60 QALYs for the general population to give a proportional shortfall of, in this case, 0.58. And proportional shortfall lies between 0 and 1. So how do we go about calculating that in practice? So firstly, to calculate that in practice, you first need the general population quality adjusted life expectancy. So you need the sex distribution and starting age. So that's the age at which the technology would be used in the population. And you would think about whether that reflects the inputs in your cost effectiveness model. You might look at the age in your trial or a registry to think about the most appropriate age to reflect the population of interest, and you can perhaps explore uncertainty. So once you've got that starting point, you can then calculate the expected years of life and the quality of life by age. Expected years of life, that's relatively straightforward to get because there's good life tables available. And quality of life by age, there's various sources that we can use. And there's some documents from the Decision Support Unit at the University of Sheffield that had talked about the strengths and limitations of those and thinking about whether they're consistent with the quality of life estimates that you're using in the rest of the modelling. And also we can think about whether you're using pre or post-COVID figures with recognising the impact that COVID has had on general population health. And then finally, we need to make sure we include that discount rate, so the 3.5% reference case rate for that NICE users. And then finally, it's worth noting that we exclude carer QALYs from the shortfall estimate. So we define severity as the amount of health lost by people who have a condition. So we remove from that any of their family members. Carer QALY benefits can still be captured in the ISA and NICE evaluations, but not through the shortfall. So once we have the general population quality adjusted life expectancy, we can compare it with the people with the condition, and that's your comparator from your model. So that's actually relatively straightforward to get, but we nevertheless need to make sure that it is reflecting the course of the condition. And that gives a slightly different emphasis to what we've seen in the past in evaluations where relative effect is sufficient. It's sufficient to just think about relative effects. But now we need to think about the absolute life expectancy. And then based on that, we present the absolute and proportional shortfall estimates, both with and without, then use that to calculate the weight, apply that within our ISA to calculate whether a technology appears to be good value for money. Of course, it's not always plain sailing. There's a number of challenging situations for applying the severity modifier. And there's no guidance that we could give that would cover every single circumstance. So there's a number of different challenges that we encounter, and perhaps not wanting to go through all of these in too much detail, but you can see on the slides how we'd approach those challenging situations. And the answer is, in most cases, for the committees to deliberate on them and explore the challenges and consider the overall, within the overall decision, the appropriate approach. Finally, just to note, in the highly specialized technologies program, which is our program for very rare conditions, we don't propose to include the severity modifier. Although we were keen to align our programs as much as possible, it's not appropriate to use severity in this program because the highly specialized technologies program is already an exception, and it already acknowledges the challenges and difficulties, and it reflects the fact that conditions in that program have to be severe by definition to get in there. So it wouldn't be appropriate to apply severity separately. And with that, I'll hand over to Lorna to talk about uncertainty.
Thanks, Ian, and hi, everyone. So next slide, please. So we've split uncertainty into two different categories, firstly around understanding and presenting uncertainty, and secondly, uncertainty in the decision-making context. So we've split the presentation in that way as well. Next slide, please. So firstly, we'll go through the changes that have been made around understanding and presenting uncertainty. And as you'll be aware, uncertainty is present in every health technology assessment. Generally, there are 3 or 4 types of uncertainty that are considered during the decision-making. That can be structural uncertainty, parameter uncertainty, and the choice of data and extrapolation of that data. And together, these elements contribute to the overall decision uncertainty. The methods review has made incremental improvements driven by evidence, as Ian said, and we've made these across each of these categories. So we're going to take each of these in turn. Firstly, structural uncertainties. Example of structural uncertainties include how different states of health are categorised or how different pathways of care are represented in models. And the previous NICE methods guide highlighted the importance of investigating the effect of structural uncertainty on cost effectiveness estimates. However, it often received relatively little attention, especially compared with parameter uncertainty. Parameter uncertainty describes the uncertainty in the true value of the input parameters, and those can be things such as health outcomes, utilities, and resource use. And the updated methods considers probabilistic sensitivity analyses and the correlation and clinical plausibility of input parameters. Extrapolation of the data was also carefully considered during the review, as it's often the principal source of uncertainty in evaluations. This is because the relevant time horizon is usually substantially longer than the duration of follow-up in the relevant clinical effectiveness evidence. Finally, we considered how to present these uncertainties, because we know without an overall assessment of uncertainty, there are risks of uncertainties not routinely presented being given less attention in the decision-making. So it's important to note here, as Ian said earlier, that the methods review isn't the end of the story, and there's still a lot of ongoing work, especially around the presentation of uncertainties to committees, and that we can undertake that outside of the methods review, and that's still currently ongoing. So here, thanks Ian, we've picked out some highlights and some spotlights on a few new areas of improvement, but I direct you to the task and finish group reports from the methods review for more information. These outline in a lot more detail the research and the evidence behind why these changes were made. And there are also a lot of additional changes that we don't have time to go through today. So here, kind of like, what are the highlights? Bear with me, this is quite a busy slide, but we're going to move clockwise from the top left box. So we'll consider probabilistic estimates first. So the 2013 methods guide asked for probabilistic estimates, but decision-making often relied on deterministic estimates, and these don't reflect the parameter uncertainty. So in the updated manual, it states the decision-making estimates should come from probabilistic analyses unless the model is linear. And this will mean that there's a greater focus on model parameters. We also note that the distribution of those parameters should be fully justified and represent the available evidence. The updated method guide also notes to carefully consider correlation between the parameters and the number of model simulations needed for PSAs. So moving on to modelling and picking up on the changes I mentioned previously to improve the exploration of structural uncertainty and the extrapolation of data and evaluations. So the previous methods guide highlighted that structural modelling assumptions should be clearly documented and supported, but a transparent account wasn't always provided. So amendments have been made to strengthen the requirements for transparency and to ensure that decisions about model structure are clearly set out and that those are justified as well. And this will really support committees in understanding what structural assumptions have been made and why they've been made, and ensure the effect of those structural assumptions is appropriately investigated. We also want companies to set out clinical expert involvement, and especially where this has been used to inform the model assumptions. We've also highlighted here the use of flexible methods to extrapolate data. In recent years, we've seen that standard parametric models have been seen to be quite inferior to flexible approaches such as mixture models or spline models. And that's been seen quite across quite a few evaluations. So the updated method guide requires flexible approaches to be routinely considered. Moving on to the bottom right corner and focusing on net benefits and specifically net health benefits. So we know that when two or more technologies are being compared in an evaluation, the cost effectiveness acceptability curve can become less useful. They can become cluttered, and they can potentially actually conceal some of the uncertainty too. So instead, we propose net health benefits can be used. And we emphasize the kind of three situations where net health benefits are particularly useful. So those are when multiple technologies are being compared, when modifiers are applied, or for when technologies are associated with small health gains. And although we know that they can be particularly useful in those three situations, we have asked for these across all situations as well. And our final spotlight in this kind of bottom left-hand corner is on clinical and plausible scenarios. So we saw previously that uncertain parameters have been included in the analyses shown to committee, and these may well have been unsupported or clinically implausible, and they may have been given undue weight in the decision-making process. So the updated methods guide aims to ensure that all input values are derived using methods that are consistent with the data, and that scenario analyses have plausible input and parameter ranges, unless they're specifically being used to show that the results are robust to change. We've also clarified the use of threshold analyses, and these to be used when there are uncertain input parameters to consider how the cost effectiveness estimates may change based on the input used and the range of that input. As I said, there's more information on these changes and others in the NICE methods review reports, specifically in the uncertainty task and finish group report. Next slide, please. So we're now moving on to how we consider uncertainty as a decision modifier. Next slide, please. This is a quick recap of what Ian went through in his presentation before of the modifiers. And we can see in this kind of grey row in the middle here, there was no case for inclusion as a modifier for these particular areas, but there was a statement about further consideration on how they should be accounted for in decision making, and it's here in the consideration of uncertainty that they'll be incorporated into that decision making. Next slide, please. So during the evaluation process, committees consider the likelihood of decision error and its consequences for patients and the NHS. The new manual kind of maintains the principle that more caution is taken when recommending a technology when there's less certainty about the evidence presented. We emphasise the need for a higher standard of evidence wherever possible, and in some cases we have mechanisms to resolve uncertainty through managed access programmes and ongoing clinical trials. But when evidence generation is difficult, we've formalised this process of applying additional flexibility and committee making recommendations accepting a higher degree of uncertainty, specifically for rare diseases, populations that are predominantly children, and innovative and complex technologies. And this isn't something new. Committees have been doing this all along. This is really just a formalisation of what committees have already been doing. Next slide, please. So how is this applied in practice? We can see here on the top that cost effectiveness estimates often sit across a range from the company base case to the external assessment group prepared base case. And committee have to consider the sources of evidence, the input parameters, the uncertainties, and it often sits between the two of those. And when they're considering these, they'll consider both the decision risk and the context and why the uncertainties have arisen. So we can see on the left-hand side of this diagram that the committee may find the likelihood of consequence of decision error is low. For example, if the overall impact on the NHS is small, or that decision risk is high if the drug is going to be used by millions of people every day. But alongside this, the committee will also consider the key uncertainties in the evaluation and whether those are associated with evidence generation difficulties, and so flexibility should be applied. For example, if it was unethical or impractical to do a long-term RCT and the main evidence was in the duration of benefit, that would be associated with evidence generation challenges, compared to if the main driver was in the cost of the drug, or if there was no particular evidence generations in affecting this. Committee will then make a recommendation, taking into account the condition, the evidence, the ISA, the uncertainty, and importantly, they'll always consider this proportional to the evaluation context. Next slide, please. So what are the practicalities of this? The company will be expected within their evidence submission to include justification about how key uncertainties relate to the evidence generation challenges. To emphasise, this isn't a tick box activity. Saying this is a rare disease or an innovative technology wouldn't provide the clarity on how the rarity of the disease or the innovative nature of the technology relates to those uncertainties. Committees will need to consider the evidence and make a deliberative decision about whether or not to accept greater uncertainty. And that will be based on how those uncertainties have arisen, how the uncertainties relate to challenges in generating the evidence, the nature, the scale, the consequence of the decision uncertainty, as we saw in the previous slide. And again, this will always be considered proportionally to the evaluation context. Next slide, please. So a couple of quick examples to illustrate this concept. The first example is focused on condition A, and I'm going to read out these small bits of information in the box on the left. And whilst I do, what I want you to do is to consider whether or not you think flexibilities would apply. So for condition A, this is a rare genetic condition. About 1 in 10,000 people are affected. The company used disease-specific quality of life tool in its clinical trial, but there's no algorithm to map the results to EQ5D utilities. No EQ5D estimates are available for the specific population of interest, and it's difficult to validate the disease-specific tool in the limited population size. Clinical experts also explained that health-related quality of life estimates from the literature are likely to underestimate the impact of the condition on patients. So if we can click, please. Perfect. So yeah, this is an evaluation where flexibilities might be considered. And again, this isn't a tick box. Committees will still have a consideration of these uncertainties. So they might consider if the population size reflects a situation where it would be difficult to generate the evidence as is suggested by the company. They also might think about other things like, is this situation where it's reasonable not to use EQ5D? What are the impacts on the cost effectiveness results? Are utilities actually a key driver of the ISA? And is it possible to perform scenario analyses using the health-related quality of life data from the trial? And what's the impact? Does that show whether these are a driver of the ISA? Next slide, please. So we've got another example here. The second example is focused on condition B and technology X. So I think maybe if you click in again, we're going to. Perfect. OK, so this is showing me the answer already, but that's fine. So condition B is a lifelong condition, and it's usually treated with NSAIDs. Treatment X is a first-in-class drug. The company presents evidence from an RCT comparing treatment X plus standard of care with placebo plus standard of care. Survival from the trial were relatively immature, with 84% and 77% of the people still alive in the intervention and placebo arms, and the trial is still ongoing. The committees noted that treatment X is new, innovative treatment for condition B, but it has a high budget impact. So for this one, we think that the key uncertainty is really about the immaturity of the data. So flexibilities might not be applied, but some of the considerations that the committee would make are around, does the innovative nature of the technology cause evidence generation challenges? They haven't seen anything from these pieces of information, but maybe they delve further into that to think about whether there was anything associated with it. Is the survival the key driver of the ISA? Is this a situation where managed access could be appropriate? And could the uncertainties be resolved through additional data collection? And then what's the impact of that high budget impact on the decision risk? So again, considering both of those sides of the coin around decision kind of risk, and then also the flexibilities and how those uncertainties have arisen. So that's it for uncertainties and modifiers. And we'll happily take questions on those at the end. But we're going to move on to the comprehensive evidence base. So next slide, please. So the new manual puts greater emphasis on a fuller evidence base and includes greater consideration around real-world data, but also other things like qualitative data and expert elicitation. It's important that these are applied proportionately, depending on the use case and the particular evidence that's being generated for the recommendation or its impact on the recommendation. The manual places greater emphasis on the value of real-world data for answering many questions, particularly those outside the context of comparative effects. It also provides clarity for when real-world evidence may be valued for estimating or understanding the effects of interventions. The manual defines clear principles for using real-world data across use cases and makes reference to the real-world evidence framework. Initially, this was a preliminary version, but the final version has since been published and is now available. And that framework clearly describes best practices for the planning, conducting and reporting of real-world evidence studies, and it aims to improve the quality and transparency of evidence and committee trust and confidence in using this evidence to inform its recommendations. Next slide, please. So we're going to look at the real-world evidence framework very quickly. And this is trying to set out, as I've said, best practices for real-world evidence studies. It's not trying to set out minimum standards. As I noted earlier, NICE will consider all evidence in its submissions. And the aim of the framework is to support and encourage the use of real-world evidence, to improve the quality and transparency of real-world evidence studies, and to enable informed critical appraisal of those studies. Next slide, please. The framework sets out 3 key principles. The first principle is to generate evidence in a transparent way with integrity from study planning through to study conduct and reporting. There's an emphasis on clearly defining the research question, and the framework encourages prospective planning and sharing of protocols, as well as transparent reporting, and that allows reviewers to critically appraise the study and to build confidence in using the results. The second principle is to ensure the data is trustworthy, relevant, and of sufficient quality to answer the research question. And it considers the purpose of the data and whether it's appropriate to be used to inform a NICE recommendation, as well as the quality of the data. So, for example, there might be missing data, or it may consider if the relevant variables are captured. And it might be that there are trade-offs between those that would need to be carefully considered. The third principle is to use appropriate analytical methods that minimize the risk of bias and characterize uncertainty. And this may be used for comparative effectiveness studies in the absence of RCTs, or to complement RCT data. And it builds on the NICE Technical Support Document 17, which provides guidance on statistical methods for dealing with confounding by placing emphasis on good study design. And here I'll hand back over to Ian to finish the presentation.
Thank you very much, Lorna. So I'll just finish off by talking a little bit firstly about challenging conditions, technologies and evaluations. And I'm aware that this is potentially quite relevant, I think, to the work that's ongoing in Australia. So hopefully this is interesting to give a bit of a whistle-stop tour of. We gave particular consideration to innovative medicines, so things like cell and gene therapies, histology-independent cancer treatments. In the first phase of our review, where we looked at them in some detail, we looked at the past experiences of them and the conceptual challenges. And what we found was that there's prominent challenges, but they're not unique. So there's very prominent challenges, particularly around, say, long-term uncertainty, and multi-comparator trials, which are very prominent in these innovative medicines, but they're not unique, and they're not only found in these technologies. So, as a result, and of course, bearing in mind that there's no particular societal value for different approaches to be taken in, say, cell and gene therapies versus a similarly effective traditional medicine, or not traditional medicine, standard medicine, I guess. There's no we conclude there's no particular case for specific methods provisions. So we wouldn't want to add to our methods a statement saying, if the technology is a cell or gene therapy, do this. But rather to make broader changes to our methods that can be applied anywhere to any type of technology that are particularly relevant to, say, innovative medicines. In the longer term, we also have an ambition to make sure that we have the best possible horizon scanning for methods challenges, so methodological challenges associated with new types of medicine. So when the histology-independent cancer treatments first came out, we identified those quite early, but perhaps could have been earlier, to make sure that our methods are ready for the challenge when it arrives. And to do that, we'll also need to make sure our methods are responsive and we're able to make responsive updates, which I'll touch on again in just a second. So in terms of cell and gene therapies, the updates that are particularly relevant here are around long-term benefits and uncertainties, some of the methods that Lorna described around uncertainty. Inclusion of cure proportion modeling as an explicit option for extrapolation, not mandatory, but an option that's very relevant to cell and gene therapies. The net health benefits approach, again, could be very relevant in this circumstance. And there's also provision within the methods to account for service delivery effects. And for histology-independent cancer treatments, we include guidance on the design and conduct of basket trials, and think about how we approach non-comparative studies, and really importantly in this case, heterogeneity and generalizability. Rare diseases also pose something of a potential challenge to standard methods of health technology evaluation. And the first consideration that was encountered or that we thought about was whether there was a case for a rarity modifier. Now, I touched on this earlier, but just to sort of reiterate, there wasn't evidence that society particularly values health benefits for rare diseases more highly. But we do, as a health technology assessment body, need to make sure that rare diseases are not blocked, they're not disadvantaged, they don't face inappropriate barriers to new technologies. So we conclude there's no case to have a specific rarity modifier for rare diseases in our decision framework, but rather a broad package of updates that are relevant to rare diseases to make sure that we're supporting access and making sure there are no inappropriate barriers. So the first of those is the flexibility for uncertainty when evidence generation is challenging, as very much as Lorna described, that to make sure there's no uncertainty barrier, and recognizing uncertainties are often higher in rare diseases, and there are difficulties in generating the standard of evidence that you would see in a more common condition, but making sure that doesn't become a barrier to adopting new technologies. We embed the proportionality to context throughout the methods. So thinking about a rare disease like it's a rare disease and not judging it by a standard that's inappropriate. The comprehensive evidence base and broader evidence sources become particularly important when large-scale RCTs are inappropriate or impossible. So things like expert evidence and qualitative evidence become more prominent. So there's real benefit, I think, in those changes for rare disease evaluations. And there's some flexibility included in our evidence requirements, for example, in surrogate outcomes. So this is a good example of where we can embed proportionality to context and make sure there's no barriers. So by setting standards for what we expect in terms of validating surrogate outcomes, we can ensure a degree of certainty, but recognizing that one of the high level standards would be meta-analysis of multiple RCTs, probably not feasible for rare diseases. So allowing a degree of flexibility in that evidence requirement is appropriate and it's proportionate and it avoids those barriers. And then finally, many rare diseases are also severe, so the severity modifier I described earlier becomes relevant in a lot of cases. So that kind of concludes what I wanted to talk about in terms of the methods updates. But just to quickly, and not wanting to do a disservice to my colleagues who work really hard on the process updates, but just want to give a quick whistle-stop tour of some of the process updates and alignment. The key themes from the process review are these as shown here. So firstly, aligning our guidance development processes across different technology types, across our different programs, avoiding rather inappropriate or sort of esoteric differences between what happens to be a different program at NICE, but making sure that the guidance development process is smooth, consistent, where it's appropriate. The second is opportunities for new processes and different ways of working. And then finally, commercial and managed access, which is actually, it goes beyond the scope of what I'm able to talk about today. So just thinking about those first two, one aspect of alignment on the right-hand side is terminology. This seems quite simple, but I think has quite a big impact. Any of you who've been looking at NICE's evaluations may well have noticed that the external academic bodies that review evidence for us have at least 3 different names, or had at least 3 different names across our different programs. So the external review group, external assessment group, external assessment center, 3 different names, 3 different acronyms, which is needlessly confusing and unhelpful. So we've aligned that into one EAG, and we're all now making sure that we're using that single term consistently throughout. It's taking a little bit of adjustment as we're used to different acronyms, but we're all getting our heads around it. And that's just one illustration of where we've done that. We've done similar across draft guidance, final guidance, the way we refer to stakeholders. So that's a surprisingly helpful, surprisingly important piece of alignment. There's also alignment across how we describe and how we approach the start of evaluations, so the invitation to participate, or ITP, how we approach submissions, how we approach technical engagement, which was a stage that was introduced in medicines evaluations a couple of years ago, and how we think about consultations and final draft guidance. So that's all about alignment across different programs and technology types where it's appropriate. There's also opportunities for new ways of working. So some examples here are the options for, say, shorter consultations where it's appropriate to do so, how we go about routing evaluations of medical technologies, how we approach terminating guidance reviews after a period of managed access, biosimilars, how we identify experts and recommendations outside of committee. So that last point refers to the idea that in some circumstances it might be appropriate to make recommendations or adjust recommendations without the need for a full-blown committee meeting. So those are, again, apologies to my colleagues who've worked so hard on this for doing such a short overview of this, but some of the opportunities for new processes that we've incorporated through that process review. So what happens next? This is just one final slide. The journey for methods is never over. It's never finished. But in the future, we need to move to a position where we can make continuous improvements in our health technology evaluations as the landscape continues to evolve. And that includes methods, processes, and our operations and the broader policy developments. So our new approach from here is we want to move away from the current pattern of large single updates periodically, so every sort of 5 years or so, into a more targeted and dynamic approach, a more flexible approach based on modular updates, which focus on specific topics of interest. So we need to work out how we design that, and that's all in progress now. We're working out how we design that and oversee it and how we prioritize that. But some of the topics that we may start to see in the future could include things like genomics, antimicrobials, digital technologies, and on the process side, a proportionate approach to technology appraisals is already underway, actually. We're already exploring how we can be more proportionate in our evaluations. And that's it from me. Thank you very much for listening, and I'll hand back to Bonnie.
Thank you so much, Ian, Lorna. That was really interesting, and it has obviously generated a lot of questions and thoughts regarding the applicability of some of the decision making around the NICE HTA review to Australia. So I'm really looking forward to the discussion at the end. So if you have any questions for Ian and Lorna, please put them in the Q&A box down the bottom. And I might direct the question either to either of them, but I also might address it to other presenters as well. So without further ado, I'd like to also introduce Zoe Garrett from the Science Policy and Research team at NICE, and she's going to be talking about international collaboration with other HTA agencies. Over to you, Zoe.
Thank you. Right, you can see the right slides, can't you, Bonnie? Good.
Yes, I can.
Cool. Okay, so I'm as Bonnie's introduced me, I support NICE's strategic international partnerships, including the management of the partnership arrangement that we have with the Australian and Canadian health HTA agencies. So okay, so international collaboration is obviously a very large area. My presentation will focus on a very specific part of international collaboration, which is work sharing, because of its relevance to your medicines review. And I will talk a little bit about the approaches taken in HTA collaboration initiatives, a couple of examples of HTA initiatives, and then some of the considerations around deciding which agencies to collaborate and the things you have to put in place for such schemes. So collaboration initiatives. So yes, you can work share. We have a number of international HTA collaborations that include arrangements for joint working, work sharing, and shared submissions and templates. You can see them in Europe in the United Joint Actions and what they tried to set up, the ongoing setup of the EU HTA regulation, the Benelux initiative involving the Netherlands, Belgium, Ireland, and Austria, and then the FINOS initiative involving the Scandinavian countries. The characteristics, they will have a kind of set of similar kind of broad characteristics whereby sections of the assessment are allocated to agencies. So some agencies will prepare the assessment, others will review it, and then there's kind of collaboration and communication between agencies during the assessment. They focus on the technical evaluation of clinical effectiveness, and then also in some cases health economics and budget impact models. And then the appraisal and decision making remain a national responsibility. So what you end up with is you end up with a joint assessment by all the agencies that is then dropped into their national HTA process. That sounds very easy. It's important to understand that actually it's not that easy. You can't just wake up one morning and decide you're going to have a work sharing initiative. There are some quite important kind of foundational elements that have to be put there at the beginning. So you need industry support for such a scheme because they rely on a joint submission. You need to have a process for developing a shared scope between the agencies involved. Not all HTA agencies actually develop a scope at the beginning. So you have to kind of take that into account. That kind of joint submission, so the process of having a kind of identical submission that's submitted simultaneously to all the countries involved, with or without a local submission of your jurisdiction specific information. So you have to decide, well, what is joint and what remains a national responsibility. How would that be presented so that you still end up with a kind of coherent value proposition for each of the countries involved? And importantly, where does technical evaluation and assessment end, and where does appraisal start? Not all HTA agencies have the same definition of assessment and appraisal. You have to think about how you're going to accept and manage confidential information and confidentiality arrangements to allow information sharing between the agencies involved. And then it also those exit processes. So to provide some reassurance for industry, how, if a topic goes into a joint process, how can it revert back to a national process if necessary? For example, if the regulatory process goes a bit wrong and it turns out that you can't actually do your work sharing scheme, how can it then go back into the national process for national evaluation? Importantly, I think it's important to think about, well, who are you going to work with? You can't just actually like pluck an agency out of the air and then actually create a work sharing scheme with them. Who you work with defines the likely success of the scheme, how many topics could go through the scheme, and the efficiencies that you will see. And in my head, I have 4 kind of rough questions that I would think about when I'm thinking about my partners. So the first of those is about, is the agency and the inputs into the agency broadly similar in purpose, content, and depth? We all know that HTA agencies are different. We work differently. The HTA we produce can be different. The submissions we want to see might be different. And although joint working supports convergence, that process of convergence will take longer and will be more painful if your agency start with fundamentally different remits or working practices. So it's important to take that into account at the beginning when thinking about who you want to collaborate with. The next question is there alignment in regulatory and HTA timing, or do you have the flexibility to create it? So for simultaneous submission, you require an alignment of timing. If you don't have that timing alignment, then you can find yourself in a really difficult situation where your HTA information may need updating before the last agency can use it, or the decisions at the earliest agency could be delayed. And that is likely to be, well, that's likely not to be terribly efficient. It's also likely to be unacceptable if decision-making ends up being delayed. So where you don't have that timing alignment, and even if it's like just 2 or 3 months, that can actually be really important in HTA and for patient access, especially in a culture where HTA agencies are often kind of compared, and there's that competition for early access. So where you don't have that timing alignment, even if it is only kind of 2 or 3 months, you actually have to be able to work with industry to create that alignment. And that is much easier for everyone if it's already similar. So you might be able to work with industry to kind of, bring that submission forward by a couple of months, but it's going to be much harder to work with them to bring it forward by like 8 months. So that's something that you really have to kind of think about at the beginning. Is there alignment in PICO and healthcare context? So HTA fundamentally responds to a policy question for a given jurisdiction. If healthcare contexts are different between jurisdiction, then you have fewer shared elements of the policy question. That doesn't mean that you can't do work sharing, but it means you end up with lower efficiency gains from having a shared submission and process, to the point that if you end up with a very, very different PICO and healthcare context, you can simply end up in your joint submission with 2 national submissions and 1 shared cover sheet. You can still do it, but you're not really getting your efficiency gains from doing it in the first place. And then lastly, is there alignment in methodology, or can you create it? And, where agencies have a very kind of like acceptable or preferred methodology, and that varies with the other agency, then you can end up in a situation where you have to do multiple analyses using different methodologies in order to meet the requirements of those agencies involved. And again, that results in that lower efficiency gain from having that shared submission and process. And that doesn't mean that you can't do the work sharing. It's just something that you have to take into account when you're thinking about, well, what is the scope of this? What kind of efficiencies are you going to see in the end? And is that initial resource outlay in developing the process and finding that new way of working, is that then going to be offset by the actual work sharing? So in summary, international collaborations have implemented and used sharing processes and submissions. Using a shared submission often still requires a national submission. Shared processes focused on technical evaluation rather than appraisal and decision making. The implementation of a shared process requires some very key foundational elements that need to be put in place at the beginning. And to get the most gains from having shared processes and submissions, there is a need to carefully consider the similarities between the agencies and jurisdictions across a number of areas. And that is my summary. We are, I think you will have seen from the Australia-Canada-UK partnership arrangement, one of our priority areas is around work sharing and exploring efficiency gains. So the questions that I posed earlier in this presentation, they're ones that we are starting to grapple with and actually to consider the positions we have on them. And I think in your medicines review, if you could also continue that process of considering those questions, then that would be very useful for me. So thank you very much.
Thank you, Zoe. I'm really looking forward to collaborating more with NICE in the future. And I have to say, from your presentation, it makes me realise it's not going to be as simple as I thought it was going to be. So thank you. Okay, so I'm going to, if I can get this to work, give my couple of brief thoughts about changes to the assessment of medicines. I've got it on the wrong side. The applicability of NICE to the recent recent NICE HTA review to Australia. So I'm just going to give you some of my initial thoughts. So the first thing I want to talk about is, why should we consider the NICE review? The first one, so some of the reasons are things like, so the first thing is to think about is we actually have similar HTA processes. So very, very similar in terms of the submissions by the pharmaceutical companies, and then we evaluate them. Very similar in terms of some of the processes. However, there are differences. For example, the types of medicines that are considered, there are slight differences, but also in terms of whether the meetings are public, and that probably reflects the price negotiations, which are more likely to happen in Australia than they are in the UK. And finally, differences in recommendations. And so in particular that in Australia, those recommendations are largely just recommended versus not recommended because they determine which medicines are funded or subsidised through the pharmaceutical benefit scheme, whereas in the UK there's still a lot of flexibility, even though NICE might say no. So they have more flexibility in terms of those recommendations, such as only research or recommended with managed access. The next reason why we might want to consider the NICE review is there are potential efficiencies. So, for example, NICE has produced detailed reviews of a variety of subsets of the NICE of the HTA methods, and they are available. And so I suppose we can avoid, reinventing the wheel by really considering some of these reviews. There are also quite a few similarities in scope. For example, they consider similar medical technologies, though I want to flag that in Australia, the review would also include vaccines, but didn't so for the NICE. On the other hand, NICE considers diagnostics and medical technologies. All HTA methods are on the table. And the other thing is funding pathways. In the scope for the HTA review for Australia, there is a definite consideration for rare diseases and new technologies. And these were considered obviously by NICE as well as part of those HTA methods, like for example, when they considered extrapolation methods. But in terms of funding pathways, we're also considering them as well. NICE did also consider funding routes, such as through the commercial framework and the Innovative Medicines Fund. Both are considering how to better manage uncertainty, and the PBAC HTA review is different in terms of it also considers international sharing of HTA working, so for especially feasibility and purchasing practices. So I suppose Zoe's presentation and consideration really kind of feeds into that. So another reason why we might want to consider the NICE HTA review is that there are similar methods that both use, but there are differences. But I should point out that these are guidelines, and obviously there are situations where deviations from the guidelines are obviously justified. But I just want to flag, these are just like a couple of the kind of key differences in the guidelines that currently exist between the current NICE guidelines as of January and the current PBAC guidelines as of 2016. And there are a couple of key differences to note. So particularly, for example, NICE doesn't mind a Bayesian approach in terms of meta-analysis and network meta-analysis. And obviously their results, they prefer an expected incremental cost-effectiveness ratio from the probabilistic sensitivity analysis, whereas in Australia it takes much more of a frequentist approach in both the synthesis of evidence and outcomes and also the presentation of the results and using the deterministic ISA. There are also differences in terms of the types of economic evaluations, in particular looking at those cost comparisons. So it is much more frequently used in But in Australia, they require a stronger proof of non-inferiority between two medicines, whereas in the UK, it's not limited medicines with a proof of non-inferiority. There are slight differences in the perspective, in particular, whether or not the health impacts on carers are considered. There are differences with regards to extrapolation methods and measuring and valuing health effects, and obviously the discount rate, which we're all very much aware of. And finally, there are differences also with regards to the threshold and quality modifiers and with the applicability of it, especially when we have an implicit threshold. There are, just with regards to some of those special issues that are really kind of pointed out in terms of the HTA review scope. In terms of new technologies, as Ian said, there's no special methodology identified in the guidelines, but there are different certain places within the NICE guidelines where, for example, the use of cure models, for example, has been considered. And likewise in Australia, there's no special methodology. In terms of rare diseases, as Ian pointed out, society doesn't necessarily value rarity as an important quality modifier, but accepts more uncertainty. And also some of those rare diseases or the treatments for them might be routed into the highly specialized technologies program. Whereas in Australia, again, it's much more rarity is considered implicitly through considering the other factors considered in the deliberative process, the rule of rescue and the life-saving drugs program. In terms of innovation, again, no evidence that society values health benefits more, but does accept more uncertainty. Whereas in Australia, it is not actually mentioned in the guidelines that I could find. In terms of the real world evidence and generation of real world evidence, that NICE has the Cancer Drugs Fund and the Innovative Medicines Fund, and they have this new framework for real world evidence, whereas no dedicated funds or framework in Australia. And in terms of uncertainty, both countries take a more cautious approach when it comes to treatments that are more uncertain or that are more uncertain. However, the UK explicitly suggests that a greater level of uncertainty might be considered, especially for rare diseases, children, or innovative or complex technologies. Whereas in Australia, it's implicit through the other factors considered. And also both of them have some form of managed access agreements or data, especially around data collection. But I suppose the key thing is Australia's more like, there is commercial arrangements with regards to NICE, but Australia, we're definitely more reliant on discounts and financial caps. Another reason why we might want to consider the NICE review is obviously international collaboration. So I've already mentioned this with regards to the recent agreement, but also the HTA review scope explicitly mentions the feasibility of international work sharing and purchasing practices. And so finally, some of my final thoughts. I've identified several differences between the HTA methods between the UK and Australia. And just want to point out that some of those differences might actually be justified in terms of differences in the underlying legislation, in terms of the need to consider the budget impact, differences in the healthcare system, or societal preferences. And so we need to understand not only where the differences lie, but also why those differences might be justified, and so it's okay. But just want to note that, as Zoe's pointed out, that might have ongoing ramifications. Those differences might have ramifications for international collaboration. There is a need to be very careful about changing those methods, and we should only do so if there's excellent evidence to do so, because that might create uncertainty for sponsors by changing them, and but also and whether or not their product might be listed on the pharmaceutical benefits scheme, but also it avoids having to reverse the decision if we find evidence that suggests that that change wasn't appropriate and we would have to revise those prior decisions. We should also recognise that changes in some HTA methods may affect other methods. For example, the connection between changes in the discount rate and the incremental cost effectiveness threshold. And changes in the HTA methods really should be also reflected in the MSAC methods to ensure consistency. And I would like to note that NICE has moved from a situation where there are multiple manuals to a single manual that covers all technologies. And the NICE revised methods are now only just being seen to be used and seen by the NICE committees. And so particularly with regards to the use of these quality modifiers and use of real world evidence. And so it might actually be useful for Australia to just wait and see how the committees use them and some of the issues regarding using them or interpreting them before we make any similar decisions. And finally, before I just pass on to Kirsten Howard, I'd like to point out that it's not just a one-way street. It's not just what can Australia learn from NICE, but also there are opportunities where NICE can learn from Australia. In the past, there has been, our HTA methods have gradually converged over time, particularly with regards to the use of single technology appraisals and the use of cost comparisons or cost minimization analysis, and actually also the amount of time dedicated to evaluation. But what else can NICE learn from the PBAC? Well, in my perspective anyway, definitely the methods used to justify cost minimization or cost comparison analyses. I think that's very well thought through in Australia. Also in the UK, people are very much unaware, or according to Martin anyway, people are unaware of PBAC or MSAC public summary documents. And certainly when we do evaluations, we're always interested in whether NICE has considered a technology before Australia and what was their perspective, and we find this usually unique and quite independent. And vice versa, as the NICE committees might find a value in looking at PBAC decision making. But we must be aware that there are always issues that might be unique to each country. For example, different comparators or care pathways or drug pricing. And finally, the PBAC process is quite efficient. It's a shorter time for evaluation and there's fewer meetings, which does mean that ultimately patients are able to access very valuable medicines earlier. And the commentaries or the evaluations are very structured and consistent, which means it's easy to locate information, and the executive summary becomes a public summary document, which can reduce workload for committees. So those are my initial thoughts, and I'm going to pass it on to Kirsten Howard, who will also has a wide breadth of experience, and it'll be really interesting to see what she thinks as well.
Thanks, Bonnie. Just try and get my slides up so that they actually work. Okay. Thank you for inviting me and fabulous presentation from colleagues at NICE. It's such a wonderful, comprehensive evidence review process that you've actually undergone. So thank you for sharing that with us. So as Bonnie mentioned, I'm chair of the Economic Subcommittee of PBAC and a member of the PBAC. So probably this slide was as much for my information and my reminder around the updates that we've been talking about today. And predominantly they've really focused on the modifiers, what Anne and Zoe have and Lorna have been calling modifiers. So I guess in the broader sense, they're the kind of things that I would consider to be context. So the other things that we think about. So end of life and severity of burden of illness, innovation, and what do we mean by innovation or innovative medicines? The issues around sort of rarity and the clinical context of the medicine and the decision that we're making, age, uncertainty, and discussion of the comprehensive evidence base, and in particular focusing on the idea of real world evidence. Not a term that I necessarily am completely comfortable with, because I think all evidence is, I think we should be talking about the type of evidence that it actually is, and the terminology real world evidence suggests that some evidence is not real world. So this is just to kind of reiterate Bonnie's summary. I think there certainly is value in us considering the review that NICE has done, because of the similarities in some of the ways that we think about medicines appraisal and reimbursement decision making. So I guess just taking Bonnie's table that she put up, there's a couple of things that I guess it is worth pointing out as well. That are maybe more consistent with NICE than on first glance might appear to be the case. So I think in terms of the synthesis of evidence, I guess Economic Subcommittee and PBAC do consider all of the approaches to evidence synthesis, including network meta-analysis in our decision making. The perspective that's taken, Bonnie indicated that it tends to focus on patients only. And I guess I would just kind of make the note that health outcomes for carers and non-health outcomes can be presented in any supplementary analyses. And while the base case analysis focuses on patients, even the 2016 guidelines makes it very clear that additional supplementary analyses can be presented, and that might be particularly relevant in certain contexts. In terms of measuring and valuing health effects, obviously a large majority of what we see is QALYs, as Bonnie's already mentioned. But we do still see economic evaluations and ICEs where QALYs haven't been calculated, and we've been presented with information calculated around, I guess, consideration of changes in what I would call natural units. So event rates, responder rates, those sorts of things as well. And to some extent, the tolerance for these sorts of things really interplays quite strongly with some of the things that NICE are calling modifiers, and things that I would consider to be the kind of the clinical and patient context of the decisions. In terms of discounting, Bonnie's already highlighted the discount rate. So we have a preference for a 5% base case discount rate. But again, we do consider other discount rates as additional analyses and in sensitivity analyses, and there certainly have been cases where discount rates other than 5% have been considered as part of decisions. Similarly, probabilistic models, the vast majority of what we see do tend to be deterministic models with stepped analyses, but we certainly do also consider probabilistic models and the probabilistic presentation of results as well. And I guess the bottom line is where we kind of get to we don't have an explicit threshold in making decisions or recommendations, and really the acceptability of an incremental cost effectiveness ratio is really dependent on the context. So that might be the context around the clinical place in therapy, the availability of alternative treatments. It might be around particular patient characteristics, clinical need, and also the level of the certainty we might feel that there is in the evidence, in multiple types of evidence. And I guess this slide really just kind of is a good reminder of the kind of things that that we do already consider in the context of decision making. So clearly there's a lot of things that are quantifiable, including health gain, cost effectiveness, affordability, and of course, as Bonnie's mentioned, the financial impact of new medicines or new health technologies in the context of MSAC. So particularly for PBAC, the use in practice and financial implications for the PBS, but also for the total government health budget as well. And I think these less readily quantifiable sort of contextual factors, I think, really go to some of the similarities that we are taking into account in making these decisions, that really do align quite a lot with some of the modifiers that nice colleagues have been talking about tonight as well. So the extent of overall confidence in the evidence, and also in the assumptions that are relied upon in the economic modelling or financial impact modelling as well. It's a specific consideration around equity issues, so implicit equity and ethical considerations around different patient groups such as age or socioeconomic or geographical status, and that context is obviously going to vary for different submissions. The other less quantifiable things include things around the presence of effective alternatives, the extent of clinical need there might be, the severity of the medical condition that's being treated, how easy it is for us to actually be able to target the medicine to the people that are actually going to benefit the most. And then the lovely catch-all of any other relevant factor that can affect the suitability of the medicine. And I would just say that these are explicitly, these words come from the guidelines themselves. They're in the early stages of the guidelines, and then in section 5 of the guidelines, it very explicitly talks about the ability to actually address or provide additional information about all of these less readily quantifiable factors. So I think in some ways, and I don't really need to go through all of these, but in some ways not having an explicit ISA threshold means that in making these decisions that the PBAC can and already does consider in its deliberations a lot of the issues that have already been raised in the NICE review, and in some ways that's actually a reassuring thing, because there is an element of similarity to the kind of contextual factors that I think committees are considering, even if the way that consideration is operationalized might be slightly different across the different contexts. So I think the other thing is that there is quite a lot of sort of interplay and overlap between some of these modifiers in the way that we might think about them. So as Bonnie's already indicated, there is no specific pathway for new technologies. But new technologies are certainly considered, and the evidence is considered in that context of being a new technology with possibly less longer term data, those sorts of things. And I did like the phrase that Ian and Lorna were using in terms of proportionality to context. And I think that's a nice way of thinking about it. In the context of rarer diseases, we certainly do have the life-saving drugs program and explicit consideration of rule of rescue at PBAC. And I think that the idea of rarity is really implicitly considered in thinking about clinical need, availability of alternatives, particularly in equity considerations. And that sort of flows through to the extent of acceptance of different types of evidence and the extent of acceptance of uncertainty in particular contexts. The innovation one, I think, is an interesting one because I think innovation means different things to different people and different things to different stakeholders. Largely, we've considered innovation via, I guess, those other clinical contextual factors. So clinical need in the context of whether there are availability of alternative treatments, whether this new medicine represents a novel mechanism of action that gives patients who failed other treatments an alternative medicine to try. I think it's also worth us sort of thinking a little bit about the idea of using medicines in innovative ways rather than necessarily innovative technologies as well. And so the idea of sort of potentially repurposing existing medications for new indications, and that TGA and PBAC are in discussions about this kind of idea of sort of repurposing. And an example of that might be the rituximab listing was broadened to an unrestricted listing that allows rituximab to be used outside the previously very narrow context of very specific listings that it had. Severity, as I mentioned, I think is already considered in decisions, and obviously it strongly links to as Ian mentioned, to end of life, but also to clinical need, the availability of alternatives, and potentially to sort of equity considerations as well. The idea of a comprehensive evidence base, I guess, we in Australia are very much a submission-driven process, and so that means that the PBAC and its technical advisory subcommittees do consider all of the evidence that is presented to them as part of the submission, including comparative evidence and also non-comparative evidence. And I guess often real-world evidence is kind of that non-comparative type of evidence. And I think that's a useful way of thinking about it. And so if evidence is presented that is not a randomised controlled trial, then we're certainly open to considering that evidence and what additional information it provides in the clinical story. And uncertainty, I think we've already kind of talked about a little bit as well. So the idea of sort of balancing uncertainty against some of these other contextual factors around clinical need, availability of treatments, patient factors, including access and equity issues, and those sorts of things, and the idea that maybe we are willing to tolerate greater uncertainty under certain circumstances. And Bonnie's already really talked about the financial uncertainty aspects, which are intended to be sort of mitigated by some of those other mechanisms. So just very briefly, some final thoughts. I think that the systematic and incredibly comprehensive approach that our NICE colleagues have taken for evaluating the evidence for societal views on considering the impact or the influence of these modifiers is impressive, and I think we can definitely learn from the information that they've collected as part of their review. I think there's clear interrelationships between a lot of the modifiers, and that's the relationship between clinical place, between clinical need, between availability of alternatives, and disease severity and rarity of disease. And I think it's clear that there's a lot of interplay there between some of the modifiers. I think there's clearly value in NICE having some flexibility in the consideration of an explicit ISA, but the committee's being able to think about these other modifiers in a more sort of qualitative or deliberative way as well, which is great. Particularly when it's actually really quite difficult to potentially quantify some of these modifiers or some of the criteria that might be being used for modifiers. I think from our perspective, it might be worth us considering being a little more systematic in the way that we kind of characterise and assess the impact of uncertainty as well going forward. So, for example, you talked about threshold analyses, and this idea of sort of clinical plausibility of threshold analyses, and I think that really kind of links into this idea of interpreting the framing of that interpretation of that uncertainty benefit trade-off that you might get, and how plausible it is that you might actually achieve a clinical benefit of a particular magnitude that really gives you an idea of how big the benefit needs to be before something appears to be cost effective. There's obviously we need to be thinking about the different types of uncertainty and how we can appropriately characterise the impact of those uncertainties as well. I think there's definitely scope for potential collaboration across the international agencies, and that as Zoe talked quite comprehensively about, those discussions are ongoing between the Commonwealth Department of Health here and CADIF and NICE particularly. And in the clinical evidence evaluation, I really, particularly in that space, I think there is scope for potential sharing. And I really like Zoe's four questions to consider. It's a nice way of thinking about things. No pun intended. And I think I'd just like to finish by actually saying that I think in the Australian context, by not having an explicit ISA threshold, it really does mean that we're able to take account of these, what I would call context factors, and that our NICE colleagues are calling modifiers here, so that we can already and do already consider a lot of these issues in quite a deliberative way as part of our decision-making process. So thank you, and I'll stop sharing there, Bonnie, and open it up and hand it back to you. Thanks.
Thank you so much, Kirsten. I think it's really, really insightful, and actually I think the point about the implicit threshold, I think is one that I was been thinking about, and actually there's been some questions in the question and answer section about the applicability of quality modifiers, and Australia doesn't have a threshold. And I suppose it also applies to things like can we use net benefit, and also like threshold analysis as well. It is problematic without an explicit threshold. We do have a little bit of time for some questions. One of the questions that I noticed, there's a couple, there's some similar themes. So firstly, I just want to go to Zoe. There's been a couple of questions, particularly, I'm going to pose like 3 questions to you. The first one is, how do the HTA assessments preserve and guarantee confidentiality regarding pricing and confidential information across agencies? And then also, what have been the most successful international collaborations to date, and with regards to which agencies or which medicines or therapeutic areas?
Okay. Yeah, I mean, I think how to safeguard confidential information and pricing. I think that is the big, I mean, that was one of the foundational elements that I said needs to be put in place. I mean, fundamentally, you have to find a way of actually allowing agencies to, well, either to communicate with each other about that information, or you have to create a kind of boundary that says, this is the joint bit, and then this other information is jurisdiction specific. So I know that was it in Finos? So I think the Scandinavian ones, then you can put in a kind of jurisdiction specific cost information into it. So I guess what they're doing is evaluating a kind of common model into which pricing specific, jurisdiction specific prices would be slotted in basically in the national process. But I do think that in terms of thinking about the clinical trial data, you probably have to get to a point where actually you can actually communicate with each other across the agencies about that information, because I think that's quite a fundamental part of the technical evaluation, really. So I think there are different kind of solutions depending on the different information. But I don't think that if you're talking about work sharing and that collaboration, that I don't think you can there are some types of information that I think you're going to have to negotiate sharing and confidentiality waivers to allow that. So I think that's one of the things you have to kind of talk through. You have to talk through with industry as well. And you have to kind of make them aware of that is actually one of the consequences. In terms of the success of the collaborations, I mean, I think that I think what you notice is that they all take quite a long time to start up. I think both Benelux, the Finos, they took quite a long time to start up, but they're now seeing topics come through, and I think they are. I think they're quite successful in actually sharing that work. But they are also, if you look at the people involved in Finos, you've got your Finnish, your Norwegians, your Swedish, they kind of are, they're kind of geographically similar. They share the same regulator. There's kind of similarities within them. Benelux has started with Belgium and the Netherlands. Again, that geographically similar space, the shared language, all those kind of things. So there's definitely something. And then when you actually start like expanding it out into the EU, I mean, we took 3 joint actions to get to the HTA regulation. You have the whole stuff around the kind of setting up of the HTA regulation and having to develop that joint submission, which could contain many different PICOs to meet the needs of all the member states. You've obviously got, that the scaling up of that to reflect all the EU countries is not without its challenges. So I think that you can kind of look at them, but you can kind of see a pathway that actually it's probably best to start with someone who you're most similar with a small scale, and create a model with just 1 or 2 partners with whom you're most alike, and then kind of expand outwards. I mean, I would say that for things like Finos, you're actually doing the cost effectiveness, you're actually sharing the model evaluation. And that is the area where HTA agencies tend to spend most of their time. We all talk about sharing out the clinical evaluation, but if you actually think about how much time you spend doing that clinical evaluation, if your decision making is actually centered on cost effectiveness, you could gain a heck of a lot of efficiencies if you could actually just share out that kind of model busting at the beginning, and then lift in the jurisdiction specific pricing information for your committee decision making. But then you have to manage the differences in the reference cases and how you might want the analysis presented. So I think all these kind of things that you have to kind of balance out and take into account, where are you actually spending your time? Because I bet in Australia, you also spend quite a lot of time thinking about your economic models. And that's where you're putting in a lot of resource into your technical evaluation.
Yeah, I think that's really interesting about like starting small sort of thing and working coming up with a successful collaboration and then going from there rather than trying to collaborate with 5 potential agencies all at once. So yeah, that's a really good point. Unfortunately, we have run out of time, which is really unfortunate because I was really looking forward to a good question and answer session. If you, I think, can I just say for the presenters, are you okay with people emailing them if they have any burning questions? If that's okay. All right, well, okay, well, so thank you so much, everyone. That kind of wraps up everything today. And thank you so much for Kirsten, Ian, Lorna, and Zoe for your time. It's been incredibly insightful and definitely some food for thought. So, so for everyone, good night if you're in Australia, or good day, and enjoy the rest of your day if you're in the UK or elsewhere in the world. All right, thank you so much. Bye.
Thank you.